Welcome to Evening Rounds, a podcast that takes you behind the scenes in medicine. Tonight, we're talking with Dr. Jaqua, a family physician who loves connecting with her elder patients by sharing her own health challenges and triumphs. If you like what you hear tonight, please subscribe. Claire, thank you for being on our Evening Rounds podcast.
Of course. Thank you for having me.
We often have different career ideas as a child growing up. I haven't really come across many people who had dreams of being a professional volleyball player.
That's right.
So talk to me about that. I find that very fascinating.
Well, so I was born in Brazil. And as you know, Brazil very good, we are very into sports, soccer, and actually volleyball is a big deal there. So since I know me as a person, I want to be a physician. But with, childhood and adolescent, I started playing a lot of volleyball at school, in the place that we lived, almost every day. And I was getting good at it. I was invited to play at the high school team of the school. We were traveling. It was a 7-day Adventist school. So we were competing amongst 7-day Adventist schools and then other schools. And I told my dad, Dad, I think I can do this. And he's like, well, I like the doctor idea better.
Yeah.
But, if you want to try, I can put you on a school to start playing on regional teams and see if you're able to go further. But at the same time, I was accepted at medical school. So I started and, I was like, okay, I think I need to improve a lot. I need to practice a lot, but maybe I can do it. But I was not able to do it with the medical school. I was not able to train at night, and I had to study. So I thought I could do it both, but then I said, no, I need to pick one. And medicine is my passion, in forever. So bye volleyball, I'm just going to do you as a hobby, but not as a profession. And even my dad told me honey, you're good, but you need to be extremely good to be a professional player. I said, thank you, Dad, for the support. But so medicine was the right choice.
So as a fellow volleyball player, I have to know, what position are you?
Okay. You need to help me because I don't know the word in English.
Oh, yes.
The one that stays in the middle and then passes.
Oh, you're the setter.
That's right.
Yeah. I'm impressed you know that.
Well, why are you impressed that I know
well
that?
Done. Well, he does know
I was
sport.
MVP of our volleyball team.
Oh, here we go. All the confessions are coming out.
I was weak side hitter.
I did not know that. Me too.
You were weak side as well?
Yeah.
Well,
opposite.
we should start a volleyball team.
Yeah, we should. That's what it is.
We have the front line sorted out.
Yeah, we know who we got. That's awesome. What I love about volleyball that I tell everyone about is that it is one of those sports that you can be the best person on the team. But if the rest of your team isn't there mentally, if they aren't there supporting you, if they are not there and they're not strong,
that's right,
you can't get the ball over the net. You cannot get a point. And so how have you seen volleyball translate into what you do today? So
I'll have to say that I'm very better now, but I was very competitive. So there was some times that I was even so bad, pushing my colleagues away to get the ball, because I was not sure if they were able to. But, and that showed me because a lot of the times I was not able to. I was no, I need to know my place and we need to work together, and I think in medicine is the same thing. Yeah. Nurses, learners, I like to see us as a equal team, I need them, they need me. And I think it's the same with the volleyball team, with the playing volleyball as well.
Yeah.
So you are a specialist in geriatric medicine. For our listeners, tell us what that is.
So I did my family medicine residency, and then the geriatrics is because I wanted to take care more of our older patients. After my training, I did my residency here as well. I saw that if you were very good on treating older patients, because they're so complex, so many chronic problems, so many medications, I think you can treat everybody else. So I had this mentality of they are more challenging. So I want to have this extra training. And also we don't have too many geriatricians right now, unfortunately. And I see sometimes my residents, they're like, but Dr. Jaqua, because how can you do it? That visit takes too long because sometimes they cannot hear you, or it's just so difficult. They have so many medications, and I said exactly. But we are all going to that place one day, and we need to. We need to care for these patients. And I think what touches me the most is the nursing home. So like they are so lonely, not the family, sometimes they don't visit them as often. So sometimes the only familiar face that they see, it's me, like once, 2 times a week. So I have this kind of
soft spot there.
Yes, for the older patients. Yes.
I'm fascinated by cultures, and I'm curious how your Brazilian heritage, growing up in Brazil, what are some of the similarities or differences between the practice of medicine in Brazil and in the United States?
Okay, so let me answer the last question first. So it's very different. In Brazil, we have lots of physicians. Lots of physicians. So you need to gain your spot, So, for example, when I see a patient there, I spend at least, I'm not joking, an hour with the patient. So you have that relationship because you want the patient to come back. Otherwise, they're going to go to the next door or the next door because there's so many, especially on the big cities. On the small cities, we don't have it because nobody wants to go to the smaller cities for the reasons that we know, unfortunately. But you need to captivate your patient to stay with you. So you develop this relationship that is most like friends. It's just like a friendship, Like my doctor used we text each other, for different specialties. But because you create that truly doctor-patient relationship, which sometimes can cross some boundaries, but I think that's where we do it over there. One thing that is interesting too, that is different, is that now family medicine is kind of coming more popular right now, but when I did my medical school there, was not. So if you have a cough, you go to the pulmonologist. If you have, so it's very specialty based, and there's nobody to do the coordination of care. So somebody prescribe you something, or another specialist is prescribe another medication, and at the end we don't know we don't know who is prescribing what because we don't have EMR, everything is on paper. So that can be challenging for the patient. But very specialty based, and you spend a lot of time with the patient. So it's just you just need to rent one office with one room. That's what you need because you're just going to be seeing one patient at a time.
What has your Brazilian heritage or your experience as a physician in Brazil, how has that translated to your practice here?
I try to do kind of what I learned, and having my patient as my friend. When my patient comes to see me, you just need to see me maybe 2 or 3 times, everything about my family already. I like to have that icebreaker, that relationship, even though here I just have 15 minutes or so. I try to develop as much as I can that friendship, or hey, I want to know a little bit more about you, but hey, let me share something about me as well. So when I see my schedule full of patients that are my patients, I was like, today's going to be a long day, because it's not just the disease, is the whole person care. So they want to know how things are with me, pictures of Celine. I even have patients going to my kid birthday party just to see of that extent.
That must be really hard to try to keep that into little 15-minute appointments, especially when you're wanting to really develop that relationship. And you mentioned that, you have the photo of your daughter, and your daughter plays a very big part of your life and sharing that with your patients. Tell us a little bit about your daughter. We often don't allow phones on the table, but today it's a special day. We're allowing a phone on the table. Can you tell us a little bit about why?
Sure. So my daughter, unfortunately, was diagnosed with diabetes type 1 when she was 3. She turned 3 a few days later, and is exactly how you read on the books. She was like urinating a lot and drinking lots of water. I was like, there's something wrong. So I told my husband, like, I think she has diabetes. And he's like, oh my goodness, no, of course not. And I just was observing her. Then the nanny at that time had diabetes type 2. She brought her glucometer. When I checked, was like 380 something. Was on a holiday, I think was President's Day. Then I took her to the Children's Hospital. Thank goodness she didn't have to go to the PQ. We were able to manage just in the floor, but her A1C was 10. So that day I was like, oh my goodness, was the worst day of my life. And it was COVID time. So my husband couldn't be there with me. It was just one person. It was hard to do the switch. So I stayed there with her the whole time. And for sure, it changed everything in our life. I took a leave of absence for like maybe 2 months just to kind of get like what we're going to do. And yes, I'm always with my phone. My residents, they know, my patients know that, of course, she has diabetes type 1 because it beeps all the time and it's a very loud beep. So they don't even bother anymore. In the beginning, it was like, what is that? It's like fire or something. It's like, no, just Celine. So
her alarm goes off and it goes to your phone.
Exactly. Like she wears the Dexcom.
Wow.
So I can monitor her. So she can go to school because of that, as long as we have nurses. So we are like, every 5 to 10 minutes, I take a look at my phone, see how her sugars are. So I don't mind sharing. Like you guys know, I'm overshared. So she's 68 right now. So probably she needs a snack. But let's see. Let's see if whoever is with her is going to give her a snack. So I'm just like constantly with my phone. And this happens during the visits as well. So I said, oh, I'm so sorry, it's my daughter. And then the patients, they get curious. And I don't like to say that it is a good icebreaker, but actually it is, because when I show that I'm vulnerable, they're like, hey, I have a kid with a chronic disease. I see my patients open up with me a little more. They are able to share more, or they are interested and like, but how can we fix that? And even for my patients with diabetes type 2, like, hey, we cannot do anything for her, but you can do it. You can do it. And then we don't have the diabetes type 2 anymore. So I try to use that as a tool, to kind of have this more deep relationship with my patients, and also to have them open up with me, because I got you. I know what you're going through, Yes.
Yeah.
So I want to take this as an educational pearl moment, because some listeners may be saying, well, you said type 1 diabetes, obviously, that's a disease, chronic condition. Sure. It's an autoimmune, it's not reversible. But you said, well, but you, my patient who has type 2 diabetes, you can fix it.
That's right.
So tell us a little bit about that. How do you fix the type 2 diabetes?
So when I tell my patients, right? So the type 2 diabetes, if they can take care of their diet. So it's basically, Celine doesn't produce her insulin. And our patients with diabetes type 2, they do, but it's just, there is a resistance. So the insulin doesn't go to the cell as easier. So diet and exercise, we all know. But of course, I just don't say diet and exercise. They're going to look at me like, what diet and exercise? I ask my patient, what do you eat? What is your comfort food? What can we switch? And sometimes we have free samples for Dexcom, and we apply on our patients so they know exactly what food that they eat that increases their sugar, which is super, super helpful.
It is.
And
that's a
continued glucose monitor.
The CGMs, and which have really been transformative in our ability to track closely. Yeah,
exactly. We put on them, it lasts 10 days or depending what the one that you have, and then, or 14 days. And they can track, and they're like, oh my goodness, that's so good, because I know exactly the food that makes my sugar normal and the food that increases. And with exercise, the same thing. It makes it easier for the insulin to go inside the cell. So I try to tell my patients, like, hey, if you just change that, you're not going to have to use your insulin anymore. Celine, unfortunately, she can't, because they ask me, what can she do? I was like, kind of nothing. So it kind of opens the doors for me so I can have these conversations with them. And most of them are very like, oh, okay, I think I can do that. I think they feel sorry, and then they like, I'll do it. I'll do that too. Don't don't be on insulin anymore, you know?
Yeah. It's really empowering that they can, be able to have that in the palm of their hand and be able to have that understanding.
Yeah.
But I think even more so that you're relating it and you're also kind of living it. I know you've had a very transformational health journey yourself.
Yeah.
So you're really kind of living that healthy lifestyle for them too.
Exactly.
How do you kind of convey or talk about maybe your own journey in health and diet?
Yeah, so same thing. I give Celine's example. I give my example, especially with the patients with weight problems. I never had any weight problems in Brazil at all. Always skinny. And once I step my foot here in the United States, boom, something happened, which I was like, is the air, is the water that has calories here? What is the problem? Eating the same thing.
Yeah.
But I think the food is different.
Yeah.
It's not as fresh. I don't think it's as natural as it's supposed to be. So I gain a lot of weight, probably how many pounds? 60 to 70 pounds since I came here. And of course, residency, which is not the best.
Very stressful.
Exactly.
Yeah.
The
Not
best
a lot of time. Yeah.
to lose weight. And then pregnancy, COVID. Anyway, we call like the excuses of life. So I started, like I told my husband, no, that's enough. Like I'm not feeling good. I'm with prediabetes. I have high blood pressure right now. So things are going downhill. So I started to exercise like most of our patients, and you don't see the results. Actually, you see the opposite. You start gaining weight because you eat more and you're gaining muscle mass. So I was like, oh my goodness, what am I going to do? So my husband, because I'm also obesity medicine certified, he's like, well, just take the medications that you're giving to your patients. And I was like, you know that I don't like take medications. I don't like to go to the doctors and take medication. That's why I became one doctor,
Right.
So, anyway, so I try the weight loss medications that we have on the market right now. And it really, to me, I see them as a push, because with the exercise and diet, you need to give time, 3, 4, 5 months to start seeing the results. And it's very hard to be compliant with all that time without seeing one little less pound.
Yeah.
What I saw on the medication is that, okay, I'm losing it. That gave me the boost that I needed to do, like, okay, let me change my diet. Let me change. It's working. It's working. So I was able to use for a few months, I'll say 5 to 6 months, and able to get out of the medication completely, because it was easier for me to do those changes while I was seeing the results and then tapering the medication out. So I tell that to my patients. Of course, each person is different. Each person responds differently, but I give them some hope. And of course, I show pictures from the before and after.
Yeah.
That's so powerful, though, that you're able to really give them that very personal perspective of how you get it. You know how hard it is to lose weight, to make those lifestyle changes, and to do it all as a package.
Well, I think what I appreciated about what you said, you need that positive reinforcement, right? And just from a motivational perspective. And if you feel like you're doing the stuff and you just can't, you're like, well, then why am I even trying?
Exactly.
Right? If it's not working, forget this.
Yeah.
The other thing I think is important, because these weight loss drugs are really transformational.
Yeah.
I liked your answer about you still need to do the lifestyle changes, because otherwise you stop the medication and you're going to be where you were to start with, right? So the portion sizes and, recognizing what foods are trigger you, right?
Yes, I tell all my patients, if you don't do the lifestyle changes, you're going to plateau on the medication. Maybe you're like, I'm just going to use the injections. Like, okay, but it's going to be a time that you're going to plateau. And so what? What we are going to do? And if you want to stop taking the medications, what we are going to do especially is expensive. Insurance usually doesn't cover. So we all have this discussion as it's possible. And I'm here to help you in this journey.
You have probably the most letters after your name on your title of anybody I've ever met. It's 6 or 7, as I recall.
I'm worried about the social media caption. It's gonna
be like
long.
3 lines. It'll be a paragraph.
No, just leave the MD.
But what I think it speaks to is your drive for lifelong learning.
Yes.
Walk us through that a bit.
Yeah. So, yes, did my, medical school in Brazil. Came here, did my boards and passed the boards residency. And after that, I like to take the advantages that the place gives it to me. So for example, Loma Linda, very well known about lifestyle medicine, whole person care. Kind of, I'm not saying that I was born here, but very heavy on lifestyle medicine. So I tell my colleagues like, well, let's take the certification, like, why not? We have all these resources here. We have all these wonderful people that are basically the professors in lifestyle medicine. So I started with my lifestyle medicine certification. Of course, I did my geriatric fellowship before, and I explained the reasons why I wanted to do it. And also, Kelsey, like, can you imagine me precepting with my resident, and my resident knows more than me,
Yeah.
So I was like, so I need to keep up, otherwise it's going to look bad. Or I'm going to say, sure, yes, good job, and then I'm going to look it up and make sure if it's right.
That's that competitive volleyball player.
Oh, yes, that exactly.
But that's one of the great things about having comprehensive residency and fellowship programs here is the learners push the professors, right? I mean, I think that's the whole concept of academic medicine.
Oh, for sure.
It's it's not a parasitic relationship where the learner just takes from the professor. In a true academic environment, it is a mutually beneficial relationship.
Well, and medicine changes so much. It's not like, I tell my residents all the time, after I'm done with residency, I'm done. It's like, no, this is just the beginning.
It's just starting.
It's just the beginning. And if you don't touch another article, another book, you're going to be behind.
So if you were to tell your patients one thing about healthy lifestyle, what would it be?
One thing, quit the sodas.
Quit the sodas.
Yes.
Tell us why.
So there's research out there that is like, if there is one thing that you should quit is the soda. It's just for weight, forever. It's just so much sugar. Even if I'm going to do diet, well, then we have like the artificial sugars that maybe you're not going to gain the weight, but it's just so harmful for you, kidneys and everything. But quit the soda. That's right. I usually... and some people quit the sugar. The sugar thing is too broad. It can be so many things. But I tell them, one thing, quit the soda. But doctor, I drink several, maybe 6 cans of Coke every day. I was like, okay, let's cut to 3, So try to kind of work with my patients. And one thing too that I like to do on my first visit of lifestyle medicine, if I'm talking with patients about that, I try not to cut anything on the first visit because otherwise they're going to kind of
go, hold on.
That's too scary.
Too scary. So I add things like, let's add some fruits and vegetables to all your meals. So we decide which one. So I start adding first. And then when they like, okay, I'm going to see her again, then I'll go like, okay, let's cut this down, And sodas usually is my first thing.
Add first and then take away.
Yeah.
I also I think I've heard you say, I like to de-prescribe medications when appropriate. We often go to the physician expecting to get something. And I liked your approach. One of the things I'm going to give you is to take away, probably particularly with geriatrics, this concept of polypharmacy.
Yeah.
So we have now at SAC General Geriatric Clinic, 1 half day every other week. And my residents, they're like, oh, I like this clinic because I just stopping all the medications. So I try to teach them, is it necessary? Is it essential medication? Is making maybe more harm? Whatever the patient's complaining, maybe it's this medication that there is no need. PPIs, fibrates. There's so many medications that I would just like, do you know why you're taking this medication? Then stop. So they don't even know what they're taking. Of course, I ask, do you have reflux? Usually they're going to say yes, but if it's that bad that they need that medication, they should know. And that's something that I like to spend time with my patients to explaining why they are taking these medications, the why. When the patient comes and tells me, I don't know why I'm taking this medication. So why you are taking them if you don't know? So I spend that extra time to explain the whys so they will be more compliant and maybe they won't need a list of medications that are just there just because somebody's refilling.
Is that hard to kind of get through maybe to the older generation? Because I feel like we have maybe a much... I don't want to be on meds. And I know sometimes the older generation is like, well, that's just what I have to be on. I just have to have high blood pressure, you know?
Yes, it is. And sometimes I continue medication even though there's no need because my patient refuses to stop. Yes.
If you think about it, for an internist and family medicine physician and other internal, what I would call cognitive specialties, the prescription medications are the equivalent of a surgeon's scalpel.
Yes.
We would never cut on a patient without telling them what we were using it for. But to your point, you're having this symptom. Here's 3 medications to help with it. It's a very different sort of philosophy. So I appreciate the individuals like yourself who take the time.
So I know, you're saying Brazil and culture is so different, especially when it comes to aging.
Yeah.
And I know you had a very unique experience as a young child with your grandmother and caring for her. What was that like, and what did that teach you?
Sure. So my mother, she's retired now, but she was a gospel singer for the church. So she used to travel a lot. And my grandma, her mom, basically raised me and my sister. So very special to me. And unfortunately, she developed Alzheimer's disease. And at that time, I think I was doing my medical school, but I didn't know anything better. So they did all the things that we tell our family members not to do it. They put a G-tube because she's not eating anymore. So all like the bad stuff, they were giving a lot of medications to sedate her. And was a tough time. My grandma always told us, please, don't send me to a nursing home. And we would never do, because in Latino culture, like the parents stay with the kids. We don't place them. And I'm not saying that that's right or wrong. It's just the way that we do it. And she asked us, please, don't send me to a nursing home. I was like, of course, Grandma, of course we didn't. We're not going to do that. And her Alzheimer's were getting very advanced, that she was screaming. Even the medications to make her sedated was basically not working, that the neighbors they basically threatened us to kick us out of the condominium that we used to live. So my grandma she was not there anymore. It was just the body, she was gone. And it was very hard to me, my sister and my mom, my dad as well. But we had to place her. And she died the following day. We placed her one day, she died the following day. It's like if she knew.
Yeah.
But we just didn't have a choice. And this stays with me and my mom, like it hurts. But I said, well, I'm not going to let that happen, at least with my patients, to give the education, to explain what can happen, and to, if that's the wishes, what can we help to avoid placements, if that's, of course, the patient's wishes, but kind of guide them on this journey the way that we were not with my grandma. And that was one of the things as well that pushed me to geriatrics, on top of like just knowing a little more or being proficient of how taking care of the older adult, of this challenge patient.
But how amazing that, your grandma is now influencing and helping so many patients now through you.
Yeah.
And you're able to make such an impact in their lives in a positive, beautiful way. So
I hope so. Incredible. That's the goal.
Yeah.
Very, very good. Well, I wish you continued success and passion for teaching both our patients and our learners. And again, thank you very much for being on our podcast.
Of course. Thank you for having me.
A special thanks to the sponsor of Evening Rounds, La Loma, who has provided banking services to the Loma Linda community since 1955. Their support helps us continue bringing you episodes focused on health, story, and mission.